Obviously, I think one of the biggest questions in T-cell lymphoma is how do we put all the different varieties into one group and try and get an assessment. In some ways, trying to look for a CR and PR uniformly across several disease types is somewhat unrealistic. And we have been, it's like banging your head against the wall and trying to get an expected different result. So one of the things that we have to think about in designing clinical studies is look at enriching these disease populations, perhaps the AITLs. Now, the WHO 2017 and the recent the ICC has helped us reformulate some of these diagnoses. The angioimmunoblastic T-cell lymphoma, for example, is now in a different category called T follicular helper phenotype. It also includes PTCL, T follicular helper phenotype, follicular T-cell lymphoma, and so it's now one of the largest nodal categories in PTCL. The second is what we thought was NOS, not otherwise specified PTCL, can now be subclassified into different types based on Dr. Javeed Iqbal's and Dr. Catalina Amador's approach in using gene expression and also immunohistochemistry. So in PTCL not otherwise specified, you have at least two important categories. One that is TBX21 positive by gene expression profiling, and the other one that is GATA3 positive by gene expression profiling. They have different signatures, different pathways, and also responses are different. The TBX21 have a better prognosis than the GATA3s. And Dr. Catalina Amador has brought out a very simple immunohistochemistry approach to looking at this. Just as you have the Hans criteria in diffuse large B-cell lymphoma, this is somewhat a stepwise approach, unlike the Hans criteria where you do all the immunohistochemistry tests and then say it's ABC or a germinal center type. Here you have to look at TBX21 and CXCR4 and then GATA3 and then CXCR3. So by this approach, you're able to, even without doing the gene expression profiling, sort out the PTCL not otherwise specified. So these are two big moves in the T-cell lymphoma world in the nodal categories, and this helps us enrich these patient populations. When you look at studies, and give you a couple of examples, the study that Dr. Gia Ruan is doing with oral azacitidine and CHOP in the frontline therapy, the responses is seen predominantly in the TET2 positive patients. So these are categories of the patients that fit more in the AITL, T follicular helper phenotype. And then there are other studies where TBX21, perhaps you have other drugs such as the NF-kappa B pathway inhibitors that works better. So I think that's where we are moving towards, trying to look at these subsets, pathologically speaking, and enriching these patient populations. And that way, I think when you have a response, you'll have a more meaningful response for that category.